Welcome to the American Indian and Alaska Native Behavioral Health webinar series, presented by the National American Indian and Alaska Native Addiction Technology Transfer Center. I'm Kate Trams, and I will be administering today's webinar. Today, Wendy Kalberg will be presenting Overview of Fetal Alcohol Spectrum Disorders, what we are learning about diagnosis and intervention. You may notice that underneath our slide presentation on the left, there is a poll question. So I would encourage those of you who are joining us to answer that, and so we can get an idea of who we have with us today. And we'll address that later as the presentation begins. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. The National American Indian and Alaska Native ATTC is one of 4 national focus centers which serves the ATTC network. The ATTC network is a nationwide network made up of 10 regional centers, 4 national focus centers, and a network coordinating office. The map on this slide shows the locations of the 4 national focus center ATTCs. To learn more about our center, the network, or your regional center, please visit our website. Our next webinar in this series is scheduled for Wednesday, June 4, when Dr. Camilla Venner will present an introduction to motivational interviewing with Native American adaptations. We also offer the Substance Abuse Skills webinar series each month. The next session in this series will be held on May 21st, when Denise Casillas will present Clinical Evaluation Treatment Planning. For more information on our webinar series, you can contact me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and we would be happy to provide you with CEHs. The cost is $15 to do so. The CEH request form is available for the download in the Files pod in the webinar screen. If you choose to download a file, a new tab will be opened in your browser, and you will have to click on the webinar window to return to view the webinar. If you are unable to download the documents from the webinar, please contact me using the information on this slide. Immediately following today's webinar, you will be redirected to our GIPR evaluation. We invite you to participate in this brief online customer survey. The survey asks about your satisfaction with the event and will take less than 10 minutes to complete. GIPR stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. SAMHSA uses information collected by these surveys to determine how many people have attended our events, your satisfaction with our events, and how useful our events are to you. We hope you'll assist us in gathering information about our services by participating in our survey. Before we start today's session, I'd like to go over a few instructions for the Adobe Connect system. To view the presentation in full screen mode, click on the full screen button at the top right corner of the presentation pod, which looks like 4 arrows pointing outward. To return to the regular view, click the button again. You will note that later in the presentation, we will be viewing a video, and you will have to exit out of full screen mode if you choose to use it. You'll also be muted for the duration of this webinar. Please use the Q&A pod to share your questions and comments. Your questions will only be visible to me and the presenter, and we will address your questions at the end of the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. The opinions expressed in this presentation are those of the presenter and do not necessarily reflect the official position of CSAT, SAMHSA, or the U.S. Department of Health and Human Services. And today joining us is Wendy Kalberg. Ms. Kalberg is a principal investigator at the Center for the Center on Alcoholism, Substance Abuse, and Addictions at the University of New Mexico, where she's currently working on 2 projects focused on FASD. The first looks at the prevalence of FASD in the first grade populations in the United States, and the second is focused on early diagnosis for children with FASD in South Africa. She has a background in family studies and special education and is driven to provide support for affected children and their families through the use of empirical evidence. And before I pass things over, I apologize for the sounds, but I I believe I may have forgotten to mute those who might be joining us by phone. So please ignore that, and I will take care of that just as soon as I pass things over. So thank you so much for joining us and sharing your expertise with us, Ms. Kalberg, and I will pass things over to you at this time.
Thank you very much, Kate, and I'm happy to be here today, and welcome to everyone. Today is going to be a bit of a whirlwind tour through the current state of fetal alcohol spectrum disorder work. Nowadays, we really do talk in terms of fetal alcohol effects and what consequence that happens to the individual as being a spectrum, much like autism is a spectrum as well. And so that's the terminology that we'll be using today. This is a little bit of a guide to what topics we will cover today, and I'm going to go pretty quickly. We don't have a lot of time and a lot of information to cover. So I'm going to touch a little bit on diagnosis, what's happening in the field of diagnosis, what schemes are being used, the current prevalence work, what kind of numbers we can really rely on with regard to how many children and individuals are affected with FASD. I'm going to touch some on the prevention methods for preventing further cases of affected individuals. And then at the last part, I'm going to talk a bit about what kinds of interventions have been researched and empirically proven to be successful with individuals who are affected by prenatal alcohol exposure. So starting with diagnosis, what is fetal alcohol spectrum disorders? Alcohol is a teratogen, what's considered a teratogen. And a teratogen is anything that causes actual damage to a developing fetus, much like X-ray, and in the late 40s and early 50s, the drug thalidomide caused limb defects in children. Well, alcohol is also a neurobehavioral and physical teratogen. When a mother drinks alcohol during her pregnancy, there can be resultant physical differences in the child when the child is born. There can be brain damage, developmental delays, behavioral problems, learning issues, and intellectual deficits. So this next slide is a pretty extreme example, but the top photograph of the brain is a normal brain, and you can see all of the gray matter and the all of the convolutions of the cortex that are healthy. In the bottom photograph, this is the brain of a child who was severely affected by fetal alcohol syndrome. And you can see just physically the damage that is done. And again, I need to reiterate, this is an extreme example. Many children are affected, but not to this extent. So the continuum that we're discussing is fetal alcohol syndrome when there is confirmed knowledge that the child's mother drank during the pregnancy. Diagnosis can also be made of FAS without confirmation of drinking. Then more recently, the field has been able to diagnose partial fetal alcohol syndrome, and I'll talk a little bit more about that in a minute. And then alcohol-related birth defects, and that's ARBD. And that when there are specific heart defects, cleft palate, cleft lip, some real specific physical deficits or defects that can be attributed to prenatal alcohol exposure. And then alcohol-related neurodevelopmental deficits. And as many of you who do work in this field, and I see by the poll that almost 60% of you have worked or are working currently with fetal alcohol syndrome in general. Alcohol-related neurodevelopmental deficits is a very controversial area of the diagnosis at this point, and many of us are working very hard to try to figure out what really is alcohol-related neurodevelopmental deficits, and is it really going to be possible to fully diagnose that end of the spectrum? And I'll talk a little bit more about that as we go along here. So I wanted to show you the most commonly used diagnostic schemes at this point. There's the Hoyme criteria, and Jean Hoyme is a geneticist who works with us in our group, and this is the scheme that we have published on and which we use for all the diagnoses with the cohorts that we are studying. There's the Center for Disease Control criteria. There are criteria that have been developed by the Canadians, and then there is the 4-digit code, which was developed in Seattle. So fetal alcohol syndrome, the facial features of fetal alcohol syndrome, if you look to the left of this diagram of this child's face, you see microcephaly. So we know that a child who has full-blown fetal alcohol syndrome will have what we call relative microcephaly. That means that their head circumference is equal to or less than the 10th centile compared to other children their same age. The palpebral fissure length, if you can see the small line underneath this child's eye, it's the measurement of the distance from the corner of the eye by the nose to the corner of the eye out by the ear. That's the palpebral fissure. And that palpebral fissure in children with full-blown fetal alcohol syndrome is also equal to or less than the 10th centile compared to peers the same age. Flat mid-face is just an underdeveloped mid-face. And then the lip, the philtral columns, if you feel on your own face, there are 2 columns that come down from the nose and join your lip, and those are called the philtral columns. In children with fetal alcohol syndrome, that philtral area is very flat, and they don't have a distinct philtral columns. Also, the upper lip, the vermilion border, is extremely thin and underdeveloped. So those are the cardinal features of fetal alcohol syndrome. Regardless of which of these diagnostic schemes are going to be used, those are the features that are going to be looked at with any kind of diagnostic scheme. So this next slide shows you some of the differences with the diagnoses and the diagnostic schemes. So the Washington criteria assigns scores for the different features, and then they put all those scores together in an algorithm, and there are 256 possible combinations, and they collapse those into 12 categories to make a diagnosis. The CDC guidelines really only identify children at the most severe end of the spectrum, that those children have to have all 3 of the cardinal features. They must be growth deficient and have central nervous system damage, either by function or structurally. And our criteria is similar, except that we have tried to move toward being able to diagnose more subtle cases along the spectrum. So in our criteria, you have to have fetal alcohol syndrome, either with or without confirmed drinking. You need 2 or 3 of the cardinal facial features, which, as you can remember from what we just talked about, that would be short palpebral fissure, flat philtrum, or thin vermilion border. You must have some central nervous system anomaly or functional deficit, and that can be either the microcephaly or and you must have also growth deficiency. Many times we see children who have all of the facial features, but they don't have the growth deficiency, and those are the children that are termed partial fetal alcohol syndrome. And then ARBD, as I said, is a very rare and specific, if there are specific physical features that the child comes into the world with, and there's very clear confirmation that there has been a lot of alcohol exposure in utero for those children. Then, as I said, alcohol-related neurodevelopmental deficit is an area that is just evolving, and I'm going to talk a little bit more about that later on in the presentation. So basically, children with some of the people, in fact, Ken Jones, who was the one who originated the diagnosis in the United States in 1973, believes that any child who was exposed to alcohol prenatally is somewhere on the spectrum. But we really don't have enough data yet to really fully diagnose those children. And so that's just an area that we're continuing to work on. The Canadian guidelines are very, very similar to the criteria that our group uses, and so I won't go through the specifics of that. Okay. So now I want to talk just a little bit about prevalence figures. When I first started working in this field, because my background is in special education and family studies, I had worked in services for children with disabilities for a number of years. And so when I came into this field, I just thought, wow, we just keep counting numbers. We need to get to a point where we can start figuring out how to help the affected children. So be that as it may, we still do need prevalence figures in order to know what is the extent of the issue in our population. So there are a number of ways that prevalence has been looked at over the years. There are passive studies, and most of the passive studies have come from medical record reviews. And so the commonly associated prevalence figures for passive studies is 0.37 to 0.67 cases per 1,000 individuals. Clinic-based, and my bias is that passive studies miss a lot of children because oftentimes there isn't indication of alcohol use during pregnancy. There isn't, in the medical records, physicians have not really been looking for this disorder. And so I think that's a very low estimate of prevalence using passive studies. Clinic-based studies are somewhat better because oftentimes children or individuals who there are developmental concerns for do come into the clinic, and so more children are actively then diagnosed with on the spectrum. However, if for prevalence figures, it's not such a good idea to use those ways of measuring because that can be a biased sample. The best way to do any kind of prevalence studies is to go into a full population and use active case ascertainment so that you are looking at a total group of individuals and basing your prevalence figures on those. So active case ascertainment in school studies is what we're using for our studies in the United States. We've also, since 1997, been doing active case ascertainment studies in South Africa and in Italy. So I have some of those prevalence figures to share with you today. So as you see at the bottom of this slide, there's Sterling Claren and his group in the early 2000s did an active case ascertainment study in Washington State. And their prevalence figures were 3.1 per thousand from that study. In our first wave of research in Italy, in the Lazio region of Italy, Rome, and the surrounding area of Rome, we had figures that were 3.7, 7.4 per thousand. As you see, that's quite a bit different than the passive study prevalence figures. So some of the additional estimates in the Western world, in our part of the world, and in Italy, Sampson did a study in 1997 where they determined that 1% of the population was affected by FAS and ARND. Our Italy studies, in a paper published in 2006, we basically saw that 3.5% of the children that we saw in, and what we do is go into full first grade classrooms in a entire community. So we gain consent from the parents of the first grade children, and we really work very hard to get at least a 70% consent rate with the communities. And so in our Italy sample, we found that 3.5% of the children were on the spectrum, had FAS, PFAS, and ARND. So this is a graph that just kind of summarizes the work that we've done in South Africa, in Italy, and now the work that is ongoing and isn't concluded in the United States. So in South Africa, our studies have shown that the rates of fetal alcohol syndrome are the highest published rates in the world in South Africa. So you can see that the South African bar graphs are extremely high. We're finding 84 to 98 per thousand children in South Africa, which is exceedingly high. Then when you look at the Italy study, you see that the first wave, the green bar, the dark green bar, was our first wave in Italy, and that was the close to 3 and 3.5%. The studies now that we're just in the process of publishing in the United States are also showing that we're going to be in the 1.5 to 2% range. So 15.5 per thousand to 19.5 per thousand. So the bottom line is this fetal alcohol spectrum disorders is quite a bit more prevalent than we've all thought in the past. And those of you who are listening in today are people who are out in the communities working with these individuals. And it's a very complex problem because it affects individuals, adults who have drug and alcohol issues. Those issues also become issues within the legal realm. There's a need for programs working with the women, working with correctional institutions, with health services. It's a very complex and far-reaching issue. So in general, I just like to caution people to think about some of the challenges that we have in working in this field, because I think, for one thing, when a child is diagnosed with FAS, I think it's very difficult because the mothers sometimes are kind of vilified. And so I just like to caution people to remember to approach this with an open mind and an open heart in the support that we can provide. Okay, so I'm going to turn to prevention a little bit now. So using the Institute of Medicine prevention model, there are 3 broad areas of prevention that we use in this field: universal prevention, selective, and indicated. Universal prevention are general prevention activities that promote health and well-being of all members of the population, public health and public policy. So there are posters, we've all seen them, posters, trainings in schools for all students. In 1981, the Surgeon General warned that drinking drinking alcohol during pregnancy can cause birth defects. That's a universal prevention strategy. Posting signs in drinking establishments. So here's the Surgeon General's warning. Here are some examples of postings that go up in drinking establishments. The top one from New York State, the bottom one from our state in New Mexico. Then there are general posters that can be posted and to the right, when you're pregnant, the best drink is no drink at all. And the overall general prevention message is take a pause during pregnancy. Do not drink anything during pregnancy, because at this point, we really don't understand the quantity, frequency, and timing, and how that relates to genetic background, body mass index, nutritional status, all of those confounding factors. So the message is do not drink during pregnancy. There are additional warnings, again, posters, another example of a poster. Jerome Romero here at the University of New Mexico Center on Alcoholism, Substance Abuse, and Addictions has created a lot of universal and selective prevention materials. He's created these drink coasters that have been distributed to bars in our area. And I can give people his email address if anybody's interested in some of these materials. Wraps for buses, getting the message out. Holding poster contests for young children so that you raise the awareness early on in life for these children to understand the importance of not drinking during pregnancy. And here's just a conglomeration of the different kind of prevention strategies, universal prevention strategies. So then selective prevention are measures that are targeted at the highest risk individuals. So, or not the highest risk, excuse me, at all women of childbearing age. So this is these are important prevention messages to get to all women of childbearing age, including teens and young adults. And screening for high-risk drinking is one preventive method you could use for selective prevention. So in some primary care settings, high-risk drinking is screened using some of the standardized screening tools, the audit, the tweak, the TACE, and getting targeted prevention messages to women of all childbearing age. Serving restrictions in bars is another big one. There are server trainings nowadays that are provided for preventing fetal alcohol syndrome. Okay, and one kind of prevention activity that's kind of fun that Jerome and his group take part in are called pregnant pause parties. And the adage is just take a pause while you're pregnant. Doesn't mean you can't have a drink before and after you're pregnant, but while you're pregnant, just take a pause drinking. And then there are public service announcements targeted at women who are pregnant or thinking of becoming pregnant. And we're going to show a public address announcement that was developed by Jerome Romero here in New Mexico. And so on the next slide, if you want to put your screen view into full view, you'll be able to view this brief video with me. Hang on. Okay.
Yeah, I'll just come on here and remind people if you have your slides in full screen, you'll want to take it out of full screen now because the video will be shown in another screen. So yeah, I'll go ahead and start the video now.
Can I get you anything else?
No thanks, but can I take this with me?
Of course. Have a great night.
Thanks. Hi, Mom.
Hey, honey. Just in time for dinner.
What can I get you to drink?
Just water, please.
Fetal alcohol syndrome is 100% preventable. Prevent it together, because a pregnant woman never drinks alone.
You can go ahead and
So-
go back into the full screen mode if you're viewing the slides that way now.
So that's an example of a selective prevention message. And again, these messages, we're going to show another few of these messages at the very end of the presentation. And if any of you are interested, I can give you the contact information for Jerome if you're interested in having these messages for your areas. Working with peers, peer education programs, there are peer programs in New Mexico where girls who are pregnant or who have had a child and are still in high school are working. We work with those peers to get the message out to other teens who are pregnant or are becoming pregnant. So indicated prevention are intervention treatments that are directed toward individuals who are the highest risk. Those individuals who have already produced a child with on the spectrum and who fail the alcohol abuse screening measures that you might have used. And some of the prevention activities that we in our studies have found to work well, and some of these methods you're going to have taught in the next webinars. So for example, as Kate said, Kamala Venner next time is going to be introducing motivational interviewing. That is a brief intervention technique that has been proven to be very successful with women who are working hard to become sober and who are ambivalent about their drinking. So specific approaches are treatment for alcohol abuse, access, helping women who have a drinking problem access birth control, nutritional therapy, nutritional supplements, and then using brief interventions like motivational interviewing and community reinforcement approach. And again, there is a point where the mother's drinking issues and producing a child with FAS converge. And I want to go into a little bit of discussion about that quickly here. So some of the known cofactors of maternal risk and fetal damage learned is that women with poor nutrition, low body mass index, sometimes some of the genetics play a role in how affected a child might be, just how old the woman is and when she becomes pregnant, how many children she's had previously. These are all things that affect whether she may be more predisposed to produce a child with FAS. So, and we all develop optimally when we have reliable and available attachment figures. And so when we're talking about a woman who has a drinking problem and who has produced a child with fetal alcohol syndrome, and her parenting may just not be as optimal because of the alcohol abuse. And so Mary O'Connor did some really very good work in the late 80s, looking at attachment and drinking mothers. And as you'll see in this slide, mothers who were drinking moderately and heavily, 83% of those mothers and children had insecure attachment with one another, compared to abstinent and light drinking moms, where 88% of those mothers and children had secure attachment processes. And so I think it's important to just consider the drinking and the drinking and the mother and the mother's concerns in conjunction with the child. We also know that alcohol is a depressant, and we know that when a mother is drinking and depressed, then her parenting style may be more withdrawn or intrusive, both of which doesn't benefit the child optimally. We've also, Megan Gunnar has done some incredibly good work with cortisol levels, and we know that when a child doesn't have the optimal caregiver and has a questionable environment, that can create stress and increase cortisol levels in the child, which then can actually damage the brain, the hippocampus. And so I think there's the prenatal damage of alcohol exposure, as well as some of these postnatal environmental factors that I think we all need to consider. And that also makes it imperative to be working with the mother and the child dyad together and trying to help both sides. So as a review, the areas of deficit that you see in children prenatally exposed to alcohol: small head circumference, altered muscle tone, poor fine and gross motor coordination, hyperactivity in childhood, attention, learning disabilities, language and speech problems, and mental retardation. This slide is just to give you the backup empirical evidence for each of the areas of deficit that we have determined in alcohol-exposed children. And in general, average IQ scores are about 2 standard deviations below the mean for this population. But that being said, and I've tested and worked with many children who were exposed, you can have children that score very well on their IQ measures, but have varying degrees of learning disability and behavioral issues. This just shows the normal curve of, you can see in the black bars are the normal curve for IQs. The blue are those children who are exposed, and the pink show children who are who have full-blown fetal alcohol syndrome. So basically, as practitioners working in the world and trying to help children who are affected, diagnosis is the first step, and that means, does this child have fetal alcohol syndrome, and does he have the short palpebral fissures and microcephaly and all of the physical features that I discussed to get the diagnosis. But beyond that, the individual child is going to have individual needs, and so then the assessment needs to be focused at that individual child's level and what will help him. So the areas specifically that are more recently looked at with affected children are executive functioning and spatial processing, and generalized deficits in processing complex information. So children with fetal alcohol syndrome generally have a very difficult time staying organized, planning, sequencing, just planning their lives and carrying them out. So the interventions that we're promoting are directed at preventing secondary disabilities. And what do we mean by secondary disabilities? We mean early school dropout, alcohol and drug abuse, problems of their own, having children early in life that they can't care for, joblessness, homelessness, trouble with the law, mental health problems, and premature death. This shows you the percentage. This data came out of the Seattle sample, 473 children. It shows you the percentage of children in that cohort who were on the spectrum, and what percentage of them had difficulty in these areas. So what protects those children? The things that we've learned that are protective factors are being in a stable and nurturing home. If you can get a diagnosis prior to the age of 6 years, which is really big because in the field we haven't been able to really feel like we can diagnose children before the age of 6. And so our work in South Africa now is targeted at developing criteria for diagnosis birth to age 6, so that hopefully in the future children can be diagnosed and be receiving early intervention. Never having experienced violence is protective, and staying in a stable living situation for a decent period of time. Also, again, good quality of home. And this is specific data from Seattle. So when it says 8 to 12 years, that's what came out of their data. So good quality home, making children eligible for special services as soon as possible. And then if they have a diagnosis, that helps with the eligibility and placement. And then just having basic needs met. So the areas of intervention that we know can be useful with these children are specific language and literacy training, really supporting their early language development. Sociocognitive habilitation is some work that has been done at Emory, and this was targeted at helping math competence. That's an area that the field has found is very difficult for children, counting money, understanding the abstraction of math concepts. So this program has been targeted at math competence and has increased that competence. It's increased behavioral ability in these children. It also has helped parents understand FASD better. So that's a very good program. Mary O'Connor, again at UCLA, has done some very good work increasing appropriate social engagement skills with children through using a specific social skills training program. There's a self-regulation program titled How Does Your Engine Run? That was started by 2 occupational therapists here in Albuquerque, and actually it was used in a study in the Children's Triangle in Chicago, and it's helping children understand their own sort of arousal level, their own self-regulation, so that they can use their own understanding of themselves to get to a higher state of arousal or a lower state of arousal in order to be at that just right place for learning. So that's been an effective tool. Behavioral consultation has helped children and that's counseling, therapy, helping children with self-concept, helping them increase their ability to care for themselves, and helping family needs be met. Another big area when you're talking about school interventions is to provide as much advocacy as you can for the individual in the schools, and that has really contributed to school persistence and keeping children in school. So in general, in summary, it's a complex disorder. The child is affected by prenatal alcohol exposure. Oftentimes the family is chaotic and there are a lot of issues within the family. So I think we as providers need to be cognizant of the complexities and the outreaching kind of areas that all have to work together: social work, law enforcement, education, public health, to put systems in place that are helpful to all aspects, all of the complexities. One of the things I just wanted to mention here at the end is the new DSM-5 has appended criteria for alcohol exposure and possible effects. I think it's a good start to legitimize the diagnosis and have a diagnostic code that psychologists can start to look to and use. It's been a bit controversial because now that that is introducing new terminology. Everybody's kind of gotten used to fetal alcohol syndrome, fetal alcohol spectrum deficits, but now this is talking about neurodevelopmental disorder, prenatal alcohol exposure, or MDPAE. So that's a bit of a downside, but it's just a beginning. At least there are now some clinical codes in the DSM-5. They're in the appendices because it's acknowledged that there needs to be continued work in that area before everyone is confident about making a diagnosis of ARND. So, and then some psychologists are working on guidelines for psychologists, and that's a hopeful piece as well. So in summary, we need to look at the total child, that child's quality of life, membership, and sense of competence, and looking at that through the child's abilities in all the areas, and considering that child's home, school, and community. So to sum up, as Sitting Bull said, let us put our minds together to see what we can build for our children. And now I think Kate is going to run the other 3 public service announcements leading up to some question and answer time. Thank you very much for your attention.
Yeah, thank you so much, Ms. Kalberg. And yeah, like she said at this time, if you wanted to start submitting questions, please type them into the question and answer pod. And then once we have seen the remaining public service announcement videos, then we will start to address those. So it'll just take me a second here and we'll get that next video going. And just remember too, if you had your slides in full screen mode, you'll want to take it out of that so you can see the video.
What can I get you guys to drink?
What do you have on draft?
No. We'll have 2 Diet Cokes and a chocolate shake with a cherry on top.
I'll be right back.
Fetal alcohol syndrome is 100% preventable. Prevent it together, because a pregnant woman never drinks alone.
Hey, you made it. Yeah, I would never miss our Wednesday happy hour. Are you drinking alcohol? No, not at all. I ordered this for you.
Shirley Temple?
Cheers.
Fetal alcohol syndrome is 100% preventable. Prevent it together, because a pregnant woman never drinks alone. Fetal alcohol syndrome is 100% preventable. Prevent it together, because a pregnant woman never drinks alone.
I see that there it looks like we've got one question now, but I'll just encourage questions to come in as we go. I do have a few follow-up instructions, but I wanted to make sure, did you have anything else you wanted to go over before we go into questions, Ms. Kalberg?
No, I just again wanted to reiterate that if anybody is interested in any of these prevention materials, I can send Jerome's email address and he would be a contact person if people are interested. Do you want me to just give people that?
That would be great. Well, I will be sending out a follow-up email to everyone who attended. So if you want to just email that information to me, I can include it in the follow-up email.
Very good. That's great.
Great. And someone just asked about the slideshow. Says the slideshow does a really good job of providing information that is really clear in an easy way. Is there a way I can be sent this presentation? So the recording of this presentation will be available. It'll be linked to on our website. And I'll actually include a link to the recording in the follow-up email that I'll be sending out to everyone who attended. And you can also view a handout of the presentation. It's available in the webinar screen under the Files tab to download. But I will also attach it to my email that will be sent out in the follow-up as well. All right, and one other question we have right now, Alaska Native population numbers versus other parts of the US, including various minorities. I guess the question is, do you happen to know anything about those populations and how they might vary to other minorities?
I really don't know the specific data with regard to Alaska Native populations. I believe there has been some work in that, and let me investigate that, and I can send that information to Kate if I'm able to locate that. I'll send it to Kate so she can send it out with her follow-up.
Great. Yeah, that would be wonderful. We don't have any other questions at this moment, but please, if you have a question, feel free to type it in. I'll just take a few moments to give our final instructions, and then if we have any questions, we'll come back to those. So please stay online as we close out the webinar so you can be redirected to our survey, and also watch your email inbox for our follow-up, which will include a link to the recording of this webinar, as well as the other information we've mentioned. We hope you'll be able to join us again on June 4 when an introduction to motivational interviewing with Native American adaptations will be given by Kamala Venner. And also on May 21st for our essential substance abuse webinar, which will be clinical evaluation treatment planning. Yeah, we want to thank everybody, but I do see we've gotten some questions in. So first question is, what work is being done to identify adults who have been affected by prenatal alcohol use?
I believe that we've done some follow-up with our younger cohort in South Africa, and we've been looking at the young adults in that cohort to see what their life trajectory has been. I am not certain what additional work has been done with young adult population.
Okay. And let's see, another question about the presentation. Just a clarification that the neurodevelopmental disorder associated with prenatal alcohol exposure is in the body of the DSM with a DSM and ICD-10-CM code. Neurobehavioral disorder associated with prenatal alcohol exposure is in the appendix. So it sounds like that's just a clarification note. I don't know if you wanted to respond to that at all.
Can you read that to me again?
Sure. And a clarification that the neurodevelopmental disorder associated with prenatal alcohol exposure is in the body of the DSM with a DSM and ICD-10-CM code. The neurobehavioral disorder associated with prenatal alcohol exposure is in the appendix. So I'll just share this with everyone here.
That's great.
So everyone can see that.
That's fine.
And then there was another quick question about verification that you've completed or that you've attended this webinar. I will be sending a follow-up email that will acknowledge your attendance. If you need more than that, we do have a CEH request form, which I'll attach to my follow-up email as well, and you can submit that with a $15 fee to receive CEHs for this time. But if we don't have any other questions about the presentation, yeah, I'll just thank you again, Ms. Kalberg, for sharing this with us today. And do you have any final thoughts you want to leave us with, or anything?
No, just thank you all for attending and the hard and good work that you do.
Wonderful. Thank you so much. And again, I just want to thank you for bringing this wonderful information and very helpful and important information to us and sharing it with our audience. And